So I'm delighted this afternoon to be chairing this panel session on physiotherapy leadership during COVID-19. I'm even more delighted to have two of our alumni here from the RCSI School of Physiotherapy. So we have Cliona Blake and Sarah O'Driscoll. And I'm going to first of all start with just asking Cliona and Sarah to introduce themselves, just to tell us a little bit about, when you graduated from RCSI, where you're kind of based now, and also where you're working. So Cliona, I might start with you if that's okay.
Yeah, sure. So my name's Cliona. I graduated from physiotherapy in RCSI in 2009, and I started about a year later working in Temple Street as a locum physiotherapist, and 8 years later was still there. Went over to the UK and worked in the Royal Children's in Manchester for a year, and then came back in 2018 into my current role. So I'm currently physiotherapy manager in CHI at Temple Street, which is our official new name now. And I also did a master's in leadership in RCSI as well, which I finished during COVID, which was a challenge.
That was a timely well-timed event that you did that at the time of COVID, because in fact our whole discussion is about leadership. So that's really good to hear, Cliona. So I'm going to now ask you, Sarah, just to tell us a little bit about yourself, where you're based now and what you're doing work-wise, and when you graduated from RCSI.
So I graduated from RCSI in 2003. So I worked in St. Columbkille's Hospital in Loughlinstown for 2.5 years after that. Had a year in Australia. Then I worked in Vincent's Hospital in musculoskeletal mostly for 5 years. And then I've been working in Tallaght Hospital since for the last 9 years. So in Tallaght, I was originally working as a rheumatology senior in outpatients, and now I'm working as a clinical specialist in Triad. So and I'm living in Dublin. Yeah.
Great, thanks, Sarah. So both of you currently are in, certainly in the physiotherapy profession, are in leadership roles. Cliona as a manager and Sarah as a kind of a clinical specialist in musculoskeletal triage. So that's, I suppose, why we want to hear more about your COVID experience today. And so I'll start then really with, I guess, when the pandemic hit, which probably does seem like a long time ago now. We've been on quite a journey as a society, but we'll start with, what were those kind of initial challenges you faced in your role and in your organisation? And again, I'll go back to you, Cliona, if that's okay.
Yeah, I suppose the initial thing, as you say, it seems so long ago. I was on leave, and I remember on the Sunday night watching the news going, gosh, I'm going to have to go to work tomorrow. Leave is going to have to be cancelled, because it was all kind of, media was quite frenzied. So to know what was going to be happening in the hospital, I had to go in. So that kind of was the start of it, which was the 16th of March. The biggest challenge at the beginning was, I suppose, how to keep staff safe. For us in paediatrics, we were very lucky in a way. We didn't have the clinical needs that the adult hospitals did, because, as everyone knows, paediatrics aren't terribly affected by COVID. So it wasn't the clinical pressure, it was the pressure of keeping staff safe and keeping a service going in some shape or form. So the immediate challenge is, how are we going to do that? Because Temple Street, I don't know, Sarah, if you've been there, but Helen, you have. It was never built to be a hospital. So the space and the infrastructure is a massive challenge for social distancing. It's just not possible. So we were out with measuring tapes and, putting black and yellow tape to, measuring distances for where people could and couldn't go. It seems crazy now to think of it. So yeah, trying to keep the staff safe was the biggest challenge, and trying to keep people's anxiety levels low and try and manage that. That was difficult. And we kind of thought at the beginning, well, this will be 6-8 weeks and that's okay, and it just kind of spiraled then, and it kept going and going. So I'd say the biggest thing was keeping people safe, and the first thing we did do was we moved into teams. We split our department into 3 teams, and so one team was working on site, the other 2 teams were working off site, and we rotated that for a couple of months. but that I suppose was the biggest challenge. And then to keep the service going. So how are we going to still can we see patients firstly? And if we can, how are we going to do that safely to keep both the patient safe and the staff safe as well? So there was a lot of planning. I'm very lucky to have really good team leads. We have four or five clinical specialists who also act as team leads. So it was a collective approach. There's no way I could have done it on my own. Like I didn't know what I was doing. I don't know if any manager did know what they were doing. It was new to everyone. So it was getting everybody's ideas, seeing what people thought, trying to make a collective decision. And we got things right for the most part. There are always things you're not going to get right, but it was probably the biggest lesson I have learned in my career to date.
Yeah, thanks, Cliona. I think we can probably all relate to that. You know, such a new experience for all of us, and we were all probably there going, you know, we don't have a template for this. We never had a dry run. We just have to kind of get on with it. So Sarah, I'm going to ask you the same question. So again, what was the challenges you faced in your role and also in your organisation when the pandemic struck?
So so it was a big challenge. I was actually on leave at the original start of the pandemic, so I wasn't around for the initial bit, but I know from talking to people, a big focus in musculoskeletal was to see, could we kind of keep up a service, and if we could, what was it going to look like? So I suppose in some ways we were lucky. We felt, okay, we weren't on wards. We didn't have to kind of deal with that stress, because I think a lot of the kind of more junior staff were quite stressed about having to go onto wards. Suddenly they're being pulled from outpatients, while those who are kind of more senior or in clinical specialist roles, it was about kind of stopping all triage clinics and stopping any kind of routine management. And what we looked at was just prioritizing like acute services. So we really just ran fracture clinic, ED service, and once we had that kind of up and running, that was the only time we could really see patients face to face. Everything else was very much a priority about, you know, reducing footfall, reducing, you know, risk to patients, reducing risk to staff. Another challenge was just that, you know, often staff were up because they were contacts. So even in that initial phase, we were actually down quite a lot of staff. So we were really just running this kind of skeleton service in musculoskeletal and trying to kind of protect our service. I suppose we were all a little bit fearful that suddenly we were going to close out patients and we might all end up kind of working on wards. We didn't really know what to expect. So we put our routine patients on a return waiting list. And again, like Cliona mentioned, we thought, oh, this is going to be 6 weeks and then we'll all go back to normal and then we'll all kind of resume our normal activities. But that return waiting list basically stayed till January of this year. So it actually took much longer for us to kind of clear those patients. One big change was that we looked at kind of telehealth. So where we had never been ringing patients or looking at, you know, patients via video calls, we kind of had to embrace that because that was our choice. Either we weren't going to see patients or else we tried to kind of manage them. So that was a big change, and definitely, you know, challenges with that, getting used to that, and even logistically kind of from a, you know, not even having the computers and the resources for that kind of stuff and the telephones. And so, yeah, lots of big change, all happened quite quickly. And then being reduced staff, you know, was definitely a challenge. And just that unpredictable feeling that you weren't quite sure what was going to happen next. And if you were going to be told, you just have to go up to a ward now and that's what you're doing today and forget your clinic. So, yeah, so very unstable times. But I think, yeah, looking at kind of just managing a skeleton service was kind of our priority, just to make sure that we could kind of at least get those priority patients seen. So that was, yeah, the main drive at the beginning.
Thanks, Sarah. And it's interesting because that also resonates with me that you've both said it. I think everyone thought, actually, this is going to be just a few weeks. You know, and I don't know if anyone thought we'd still be here, whatever, 16, 17 months later. I mean, it is quite incredible how this has now become so normal for us. But we certainly, I don't think anyone thought that this would be us in 2021. But you know, you've kind of highlighted some common challenges, but also obviously quite unique to your settings and the different services you're in. So that's really, you know, interesting to hear those two perspectives. So I suppose my next kind of question then back to you, Cliona, is about you know, you said that kind of sense of, you know, like that urgency or, you know, things you had to kind of hit the ground running at the early stages. Was there ever a time when you felt you know, again, you were the manager, you were trying to manage all of these different teams. Did you ever feel kind of overwhelmed or frustrated? And I suppose, how did you respond to this?
Yeah, overwhelmed. Yes, there were many moments of being overwhelmed. I suppose the big one at the time, my line manager was on planned leave, and I happened, unfortunately or fortunately, to be the chair of the HSCP managers group at the time. So I suddenly became it for all communication to my manager colleagues as well. And when I was trying to look after my own team as well, that kind of did become overwhelming at points. But the way to deal with it, you know, I just looked for help, and there, you know, that's what you have to do in time like this. You can't do things like this on your own, and I suppose that is one of the greatest positives, is to see how people rallied and helped each other out. You know, some would be overwhelmed with something at one point in time, you'd be able to lend a hand, but my manager colleagues really helped me out with that, because we were kind of rowing the boat together, and we got through. So that was kind of one overwhelming kind of piece as well. Frustration, I suppose, would have been with the goalposts kind of constantly seemed to change. And, you know, you put so much effort into making one plan, and then literally a day later, scrap that, we're now doing this. For us, we were, you know, our ICU was potentially going to become an adult ICU, and one of our wards was going to be our pediatric ICU. Our pediatric ICU would move. Then there was discussion that we would go to the Mater being our closest adult hospital, we would go there. So then we were planning for that, and it was great to see. And I think it's the true nature of physios, that we want to rally, and we always want to do. I think it's a characteristic of physios, but my team were very happy to go and help the adult services, although that was a source of anxiety for some of them, because, you know, some of them hadn't worked in adults since they were students, so that could have been 30 years ago. So they were thinking, I'm happy to do it, but what am I going to be asked to do? I'll do proning, don't ask me to do anything else. But they were happy to go. So that was, you know, I have to admire them for that. But yeah, the frustration of the goalpost changing was really hard, because you put a lot of effort into something, and then it would just gone in a day. But I suppose getting over that was, you just move on to the next thing. It was kind of, okay, that's last week's news. What's next? That's how you entered it. But that can only get you so far. So that would have been fine if it was 6 weeks, but that happening, now that has kind of calmed down a bit, but that over time gets tough. It does get hard, and you need to have a good support network around you, both, you know, at home and in work, to get you through stuff like that. I have a really great team. I have really great colleagues that you kind of just talk to, and just go for coffee, have your lunches, albeit socially distanced and outside. But and I suppose that was another challenge, in that that would have been your outlet pre-COVID, but to say to someone, oh, will we catch a coffee break together? Suddenly people are like, oh, can we do that? Are we allowed to do that? You know, so your usual ways of dealing with frustration and being overwhelmed weren't easily accessible either. So you had to be kind of innovative in that, how you maintained your outlets for relieving that pressure.
Yeah, that's really interesting point you've raised there. A couple of things there that you've said around physios, and I think you're right. I think there is a characteristic of physios. I always wonder, do you come into a program with those, or do you kind of emerge from a program with them? But that kind of just doing, you know, being a doer and being a practical and pragmatic person, for sure. And also that point about that social, that kind of peer support. And I think you're so right. You know, we kind of I suppose we kind of take for granted the kind of informal coffee breaks, and how important they are. And maybe people have seen that in the last year, you know, that we've had to move virtually or not, or just not do them, or be distanced. So I think you're really highlighting some really kind of interesting points. So thank you for that. So I'm going to pose the same question to Sarah. So again, Sarah, you know, was there any point when you felt overwhelmed, frustrated, and how did you respond to that?
So yeah, so a couple of things, like from frustration point of view, sometimes it was small things, like literally, you know, the video telehealth that we've been using is a HSC run one, attend anywhere, and it's just really not user friendly. So, you know, simple things that, like, you know, when you're doing a quiz with your friends, it was Zoom and it was very straightforward. And when you were trying to do a simple telehealth in the hospital, you ended up kind of having to book a patient on our PIMS list, on a Swift queue list, you know, so, and then often even when you just wanted to connect with them, it just wouldn't work. So all of these kind of small glitches, but really frustrating when you've got like a list of patients who you're trying to get through. You're trying to be efficient, but you're also giving patients time. They're also quite anxious at home, etc. So I think that is something that has been kind of frustrating. So a lot of the time we ended up at times just ringing patients instead of using the video health. So things like that, that just could be a lot slicker, sometimes in a hospital setting, just don't run as efficiently as they should. So I think over time that kind of stuff was getting a bit more frustrating. Even, you know, even small technical things, like even when you have to change your list, because instead of having a physical list, you have to have a tele list, just what that meant, you know, that was kind of a huge amount of work for something that sounds like a small deal. It kind of can create quite a lot of work. And so those kind of things, they were nearly like small frustrations, but over time they added up to kind of a lot of overall frustration. And I suppose people feeling that, you know, they're tired, this is just another element. They've been kind of firefighting for a long time. So any kind of little thing like that could really add to how you're, you know, how you're feeling from a stress point of view. So I think over time we just got more sensible. You streamline things, you prioritize, and you realize, you know, some patients need a video, some people don't. A phone call is actually perfect for some patients, particularly follow-up patients, you know, probably not for that initial one. And I'd agree with Cliona, though, those things like having, you know, a pod in outpatients where you have some people that you could still meet and have a coffee with is really important, because if we didn't have those people to talk to, you know, it's a hard day, because you're told at the weekends don't go see anyone, you're told stick around your house, you know. So having actually an outlet and work, and even if it's a social distance chat, was actually huge. So often we would say, even just a few of us in outpatients, like, it's quite nice to be able to go to work. Like, it's actually much harder than working at home. It was nearly nice, bit of normality to get in the car, go to work, have a day of work, come home, and nearly kind of separated things a little bit for us. It might have been more frustrating to be trying to work from home and, you know, feeling like this thing is never going to end. So I suppose, yeah, they were kind of frustrations, but having a good team and having a good pod, you know, was good. Like, looking in Tala Hospital, we've quite a lot of staff in outpatients. So compared to maybe a smaller hospital where you might only have a couple, we would have it kind of 16 often in outpatients. Now we're all in smaller groups and social distance, but at least it meant there was some semblance of normality. So there was some interaction with people. Things like meetings were obviously, you know, done via Zoom, etc. But we could kind of have a little bit of social interaction, and all of that was huge, just to get us through and kind of to make things a little bit more normal in general.
Yeah, thanks, Sarah. And I think we can all we all recognize that technology problem, because you know, again, I think you've raised a really important point, that you had to kind of embrace that technology, and maybe it wasn't you know, kind of, we didn't have a lead-in time, right? You just had to kind of get on with it. And of course, technology is brilliant when it works, but when it doesn't work, it's just the worst thing in the world. So I'd say everyone listening can kind of resonate with that, whether it be on their own work channels or social channels. And of course, as you said, you had the patients, and of course some of them had to upskill very quickly with technology and may not have been used to dealing with all these different platforms. So again, I think your kind of experiences are quite different, but actually they're also I suppose so relevant to many people listening today. So I suppose the next question then, really, as this is all about leadership, is about, you know, do you have examples of leadership from your organization? So maybe people in your organization that you saw taking on a leadership role, whether it be kind of a formal or informal role, and can you think of any of those and what that looked like? So again, Cliona, maybe I'll go back to you.
Yeah, so I suppose a local example to physio, as I said, we tend to want to do, and they wouldn't kill me now, but at the beginning we there was no one to swab. Such things didn't exist, like testing centers. And our organization, we're trying to figure out, okay, how can we get back the staff tested quickly so that we can get them back to work quickly? So I said, well, that's something physios can do. No problem. And because, again, as I said, we were lucky in the pediatric world is that we didn't. Now outpatients, we had the similar challenges to yourself, Sarah, about trying to figure out, okay, how we maintain the service. But certainly from an inpatient perspective, we were, caseload wise, we were quiet, so we did have the capacity to do it in the short term. So the team embraced it, and I know that our hospital were very grateful that we did it, because we got staff tested quickly. And that was at a time where, if you remember at the beginning, getting tested in the community services, you were waiting 10 days for results. It was not an efficient service like it is now. So that was a really big deal for our team, and they really drove it well. Other things, the nursing staff were phenomenal. A lot of them did end up going to ICU in the Mater. They were really great in their kind of flexibility and what they were willing to do. And then the other big thing is that they set up a COVID center in the hospital, which was run by like a previous physio manager who returned from another role, a service coordinator of another area returned from that role, and we had HSCPs, physios, dietitians, psychologists working in this COVID center at a weekend. So like it was, there wasn't kind of there were individual efforts, but it created this group effort that kept the organization going. If they hadn't done that, I don't know how, we wouldn't have been able to run a service, because it kept staff in work. And they did, so there was the testing element of it. They also did the contact tracing, all that stuff, when that wasn't set up within the community services. So that was a really big deal that was taken on by so many in the organization. The challenge of that is that obviously everybody thought it was going to be short-lived. So then how do you pull away from that? And that was a challenge for us. So, we tried to reopen services. So all of a sudden, we can't maybe swab as much as we had initially committed to. And you see that within the HSC, and unfortunately it lasted for a very long time. And with physios, speech language therapists being pulled into services without that kind of long-term thinking of, well, actually they need to now open their services. How are you going to, you need to resource it. That had a big backlog for, I'm sure, Sarah, for you as well, for referring people on, because community services were non-existent because they were being pulled to do other work. So they're really good examples of leadership at the time, but in the longer term it kind of ended up, what was a positive kind of became a challenge.
That's great, Cliona. Yeah, that is a really good example, as you've highlighted and spoken so well about there. So Sarah, same question to you, really about any stories or examples of leadership that you came across within your role or in your organisation.
Yeah, so kind of lots of examples. Like a real priority was, as I said, at the initial stage, seeing these acute patients and managing fracture clinic and ED. And then after a while, there's this realization that this isn't going anywhere. And there are these other patients that are just waiting, and before we normally had quite a good routine waiting list, it was kind of 3 to 6 months, maybe 6 months for patients waiting. And suddenly this has become a year, patients were just waiting, going nowhere, not getting any appointments. So a big priority was kind of looking at that and trying to nearly get different leaders within our kind of MSK group. So 2 physios were looking at our return waiting list. So we created a return waiting list at the beginning of the pandemic. We'd said, anyone who's actively in treatment, we're just going to put you on a waiting list and we'll catch up with you in 6 weeks when it's all over. And then that never happened. So suddenly there were these patients that we had to get in contact. So they were kind of priority. Then the next step was actually, how do we actually start to open up patients, but keep everyone safe, keep the footfall low, look at that. So it was another physio's challenge to kind of validate organised that. We validated the waiting list. Then another physio who was on an extended rotation, she set up a virtual knee class. So this was kind of our first initial way of actually starting to see routine patients properly. And, she set up a virtual knee class from the beginning. So the patients were kind of contacted on the telephone, and then they were, given a 6-week course of classes, but it was done through video, and it was done on kind of a Zoom link. And that's been really successful, and patients actually love it because they're happy. They don't want to have to deal with parking a lot of the times. They don't want to have to deal with the stress, particularly before people were vaccinated. This was kind of a huge thing. They could feel they were starting their physio, but they weren't at risk. So it was nearly, I suppose, kind of a team effort, looking at everyone having some role in starting to sort out this kind of longer term problem, which is still going, and still a problem, but at least it's given us, once we know you can do one virtual class, you can then roll it out to other areas, so it really starts the ball rolling. So we're still trying to kind of keep this acute service and now start to tackle this backlog. So that's, I suppose, our next challenge going forward. But at least I think it shows, even lots of people doing small things makes a huge difference to kind of that leadership, and it's kind of that shared team responsibility, and just having a bit of a goal, I guess, worked quite well. So I suppose in outpatients that has worked quite well, but it's going to be an ongoing challenge. And as Cliona said, even some community services aren't up and running, so the hospital is tending to take on some of these roles a little bit more, which I suppose is not sustainable as well. Yeah.
Great, Sarah. And in fact, that leads very nicely into my next question. I think you've probably given an example of a positive, and we'll come back to that with you in a few minutes. But I am going to return back to Cliona with that question about, what are the positives, from the pandemic? I mean, you've given us some really nice examples of that leadership and the kind of just get on with it kind of approach and getting stuck in and working together. Were there any other positives that you saw emerging from the pandemic in either in your role or in your organization?
Yeah, I would say, the telehealth is definitely, and it exists in pediatrics as well, not as probably big a cohort can be applied to, but that is definitely a positive that has kind of pushed technology on clinicians forcibly, but they possibly would never have gone there, or you would never have been able to get them to go there because they had to do it. So that's definitely a positive. A positive for us as well is that obviously we're going through merger. We're going to become one big lovely hospital eventually, and the plan would be that we'll be fully electronic. And just before COVID hit, they were rolling out a kind of a system that is a bridge to a full electronic healthcare record. It's an electronic document management system, so it's kind of a hybrid version. And they had rolled it out in an urgent care centre, our first urgent care centre out in Connolly, and the plan was to get it into Temple Street and into Crumlin. I suppose towards the end of last year was the plan, but COVID put paid to that. But we decided in physio and other HSCPs, well, the system exists, why not use it now? It means that people can work clinically from home, because with remote access, it followed all GDPR compliance. You could actually safely work clinically at home. So for the likes of Sarah is saying, that case, so that you're not able to do anything with our teams that were working off-site, they could still actually work clinically. So definitely a positive was that we embraced that system. We saw it as a way to getting through our caseload quicker. Now, obviously, the cyber attack is our single strength became our single point of weakness overnight, which isn't helpful. But hopefully we'll get back on track with that. But I do think technology in the organisation was embraced, and it's probably one of the biggest things I think for us.
Yeah, and I can imagine, technology isn't going to go away, right? It's going to become more pervasive and more integrated into our work. So yeah, so I suppose when people have to just kind of, as you say, forced into it, that that's, I think it's the same for us in the academic environment.
Here, they don't want to do it because they're afraid of it, and the kind of the clinicians who would have been against it now love it, you know? And they're like, God, you know, I just had this kind of block to it because it's yet another piece of technology. So their instinct was to say no, but when they had to experience to do it, they're like, oh, actually it's not that bad.
Yeah, fear of the unknown, perhaps.
Yeah.
So that same question to you then, Sarah, again about, you know, what positives did you see kind of coming from the pandemic, either in your role or in your organization?
Definitely agree with the, you know, technology, you know, so when it works really well. And like, there's definitely things that if everything went back to normal tomorrow, we'd still keep, you know, like those virtual classes are brilliant. Like there's some patients who just, like when you talk to them, you realize, God, they have an appointment every second week in the hospital and they're coming in, and, you know, anything you can do to reduce that hassle for them. So I think like what we even started running was sometimes a virtual class, and then there was always some physical patients who want to come in. So you're nearly running this kind of, can be physical or virtual. So it's just giving people options. So I think that's huge, you know, where in the past we were very much like, if you can't make it, that's it, you know, and patients be struggling in traffic and, you know, all the different bits and pieces that might delay them. So I think that's great. And I think that we'll always kind of keep that. Even little things like we probably never used as much in the past, just if someone's coming in and you just want to check up how they're doing, and rather than them coming all the way into the hospital, a phone call, you know, is enough advice, or, you know, when they're near discharge, and rather than bringing them in and doing all of that, that you can just be a quick phone call, and just for everyone it's more efficient, you know, and kind of reduces their hassle coming in. So I think things like the telehealth, you know, virtual, I think that'll be definitely good going forward. Other positives is probably, in a way, we've gotten to know everyone that works in your area pretty well, because we haven't been, so it's been antisocial, you're not mixing with other people in other areas, you know, and so we often mightn't see our respiratory colleagues or those in neurology for months, you know, just because we're kind of still staying in our certain areas. But from an outpatient point of view, it's been good, you know, we've all kind of been working together, and there has been that team effect, and anyone, you know, any of the kind of staff grades that rotate, we get to know them a lot better. In the past, I suppose often they would be disappearing off elsewhere for lunch, but now we all kind of have lunch together, you know, socially distanced, etc. So from a team point of view, I suppose it's good in that sense. Yeah, and that was, you know, it's been a kind of surprise positive, but then instead there's a few drawbacks on the side.
Yeah, that's you know, I think that point about the quick check-in with patients, I think maybe traditionally as physios we're used to these, you know, 30-minute appointments, and we have this very kind of you know, in-depth interaction with the patient for this period of time. And you know, you're right, perhaps this is a new way of delivering a service. You know, sometimes patients just need that reassurance, that simple advice and education, and maybe they don't need that kind of face-to-face all the time, you know. So I think that's a really interesting point you've made, and certainly something we should be kind of thinking about in the future, and that might help all our waiting list issues as well. And that kind of patient-centered approach about, you know, the options for patients, you know, the kind of telehealth versus the in-person care is definitely the way forward. So we're kind of moving on now to our last question. And again, maybe you've touched on this a little bit, but just in case there was anything else to kind of pick up from the last one. But this is then for us as a profession, you know, do you think as a physiotherapy profession, there is any kind of lasting legacy of COVID-19? Now that might be positive or negative, but what do you think is that kind of legacy left in your role as a physio or in the wider profession? And again, Cliona, maybe I'll go back to you if that's okay.
Yeah, I'd like to think that, you know, from hearing loads of stories about what physios have done and kind of gone over and above, that, you know, we're always a very well respected profession, but that even more so, like what we can do and what we can offer to our kind of our MDT medics and nurses was seen more, and that will hopefully kind of remain, that kind of reputation is further enhanced by what everybody has done throughout this. I do think that the telehealth is probably one of the biggest impacts on the profession going forward. And I suppose to be slightly devil's advocate, I think it offers great options for patients. But I remember a colleague of mine saying in a different context, we have to be careful that we don't start to talk patients better. You know, we're a hands-on profession, and you know, some people were nearly overly embracing you know, telehealth is like, let's not talk ourselves out of a job here. You know, we put our hands on patients, and I think for students, so Helen, for you, like with the college, we want to encourage telehealth, but I would worry that, you know, because we have to offer this kind of hybrid training at the moment, is that going to affect the kind of the skill set coming out of college compared to previous years? You know, could a staff grade go hit the ground running in a busy MSK department if they've maybe, you know, barely laid their hands on patients? And like, I always remember, you know, you see kind of experienced therapists when you were kind of a more junior clinician, and, you know, they just have magic hands, and there's no way of describing that. I just hope that doesn't get lost because we're so concentrated on telemedicine. I think both have its place, but I think for students particularly, we need to make sure that we don't go too far the other direction and they lose out on the basics that are our bread and butter.
Yeah, no, I definitely hear you, Cliona, because I think, you know, it is so important in our therapeutic relationship, isn't it, that, you know, whether it be even just the assessment, even if we're not doing any kind of hands-on treatment, even that physical examination of a patient, it kind of builds that rapport. And it's like, yes, I am actually checking everything very thoroughly with you. And sometimes that is really important to a patient. So I think it is part of that building rapport, and obviously the information you're getting, you can't really, there's so many things you might miss on a virtual consultation, right? So no, I totally agree with you, and certainly for our students, we definitely don't want to lose that side of things, but of course we're trying to bring the merge the benefits of both. But you know, it is good to hear that.
As a longer term, I do think the virtual stuff is probably the biggest impact, certainly in Ireland, on the profession.
Yeah, great. Yeah, so Sarah, the same question for you then. So again, for the kind of wider profession, what do you think the legacy of COVID-19 is, either positive or negative or both?
So I think, yeah, like it's, I agree with Cliona, like, you know, physios have been brilliant at just rowing in and just been really versatile and flexible and kind of going where the work was needed. So I think it's shown, you know, even the other MDT, just how kind of flexible we can be. And people, you know, when there were times when people had to go and do stuff on wards, and often as an MSK physio, it's not your comfort zone, but, you know, in the greater scheme of things, you understand that this has to be done. And, you know, it was about kind of prioritizing patients and really kind of all about kind of keeping patients safe and keeping staff safe. So I think that's been kind of good for us, you know, to be seen as a profession that will kind of go where the work is needed and be flexible. Also, I suppose what, you know, I would agree, yeah, telehealth, it will be here with us to stay. I agree, you need that mix. You know, there's certain patients that you just can't see virtually. But I do think it's about kind of choice now. And often patients are nearly going that way themselves. They're very, you know, familiar, particularly younger, but even, you know, unexpectedly, lots of patients are very familiar about how to, you know, use these virtual services. So I think offering it to them, I think down the line where they can, you know, book in to us the way they can book into their hairdresser, you know, they should be able to do that kind of flexibility. So I think that stuff is where we're probably going to have to go. And I think that gives patients, you know, a feeling of a bit of control, that they can tap in, that they're not, you know, sometimes their frustration is they're ringing and no one answered them and no one got back to them, and, you know, all those little things. But again, it can kind of affect how they look at their overall treatment, how they look at the service. But by getting those things a little bit slicker will actually be long-term more helpful for all of us. So yeah, so I think that's something that could be, there's still lots to go, you know, but down the line, it would be really helpful when we kind of improve those things even further.
Great. And about that kind of patient choice, as you say, giving them a sense of control and autonomy, it's so important, isn't it? Yeah. So you both have really highlighted, I guess, you know, your stories have really highlighted the COVID journey. And in fact, even hearing some of these points you've raised now, it's kind of, you know, bringing me back to that early period, which, you know, we're trying to forget about, but certainly you've kind of made it real again and really helped, I think, to show the physio leadership. And clearly the two of you have demonstrated leadership roles over the last, you know, year plus. And I'm sure we have many people watching and listening who can empathize and, you know, say, God, that's exactly my experience as well. But you've really given us great insight into your journeys and experience of dealing in a COVID pandemic, and let's hope this is a once in a lifetime experience. And so on that note, I'd like to thank you both for your time today. And I hope that you know, your journey in COVID becomes a little bit smoother, and hopefully we will see a way out of this. And I just want to wish you both the very best in your future careers. And we know physiotherapy is a small world, and we kind of see each other a lot in different guises. And I hope I will see at some other form of alumni events in the future. But thanks very much to both of you today for your time.
Great.
Thank
Thank you, Helen.
Thanks, Nan.
Lovely to see you.